Welcome everyone to our Future of Managing Rheumatology Conditions in the Community webinar. We're just going to wait a few moments, allow everyone to join us. Everyone will be placed on mute as they join, and we'll get started in a few moments. We'll be using the Q&A function for questions, so we encourage you to send those along. And the webinar is being recorded and will be made available to all who have signed up, and it will also go on our webpage. So do please, I encourage you to use the Q&A, and there'll be lots of time for questions at the end. So without further ado, I'm going to hand over to our chair for today, Dr. Christina. Thank you.
Thank you, Ali. Good afternoon, everyone. I'm Dr. Christina Sabokocic, and I'm a consultant rheumatologist in a community rheumatologist service, which is in Southwest Essex, and this is run by Connect Health. I will be your chair today, and I hope you will enjoy this webinar, which seems to be very, very attractive for me. This is the 12th in the series of the Connect Health Change webinar organized by the Connect Health company. And so far we covered quite a wide range of topics, coming from long chronic pain through long COVID, psychology, service redesign, or even education and career pathways for MSK clinicians. Today we will talk about the future of managing rheumatology conditions in the community. And we have a very nice line of presenters here. Each of them will speak around 8 minutes. This will be followed by one question briefly. And then I encourage you to type all your questions in the Q&A sessions. And we will answer these questions at the end of the presentation. So there will be a discussion part of the webinar. As you know, community rheumatology services are relatively new in the country and not so widespread at the moment. They are really a diversified, evolving type of services, and it's really difficult to find two identical ones in the country. This is mainly because everywhere they try to adapt to the local needs of the patients, secondary care clinicians, or even the commissioners. This diversification gives us the opportunity today to learn from our speakers the different aspects of these services. And we will see these services through the glasses of a patient, nurse, a specialized GP, and a consultant rheumatologist colleague. Now, let's not waste the time. I would like to hand over to our first speaker, Fan Kipley, who is a surviving pain advocate, a patient living with fibromyalgia, seronegative arthritis, and hypermobility. Fan, this is over to you.
Many thanks, Christina. First slide, please. Good afternoon, everybody. Today I will share my personal involvement with rheumatology in primary and secondary care. Here's the disclaimer: everyone's journey is different. How they are treated depends on the complexity of their condition, what system is in place, and the attitude and experience of the healthcare team. For me, it felt like being handed a life sentence. Next slide, please. As a result of a road traffic accident in 2004, it took 4 years to be listened to, but finally I was diagnosed with severe spinal stenosis, fibromyalgia, PTSD, and later osteoarthritis. The main symptoms are shown here in the classic vicious circle, one feeding the other and so on. For me, pain and fatigue were the main problem. Next slide, please. Ironically, the stenosis was diagnosed in less than a minute by an orthopaedic consultant who knew exactly what the problem was simply by the way I was standing. Notably, that NHS consultant was still producing highly respected academic research. The orthopaedic surgeon who did the lumbar decompression was superb, exhibited genuine understanding, was interested in what I wanted to achieve, and within 2 weeks of the surgery, I was able to take up a voluntary position that eventually led to me having my own consultancy practice and taking up a PhD. In contrast, the pain management for fibromyalgia was perfunctory and negative, reliant on outmoded biomedical treatments, the usual pregabalin, gabapentin, amitriptyline, zombie-making drugs, Kenalog injections, lidocaine infusions, which years later still affect my thighs, and the truly horrendous acupuncture sessions that left me feeling violated. There was no joined up thinking in terms of physio, occupational therapy, mental health, no consciousness of considering patient well-being. The pain service was not within the rheumatology department. I was existing because of a very low dose of coproximal until it was withdrawn nationally by the MHRA. I was then subjected to a far more dangerous cocktail of opiates that never provided the same relief. Every other codeine connotation, buprenorphine, naproxen, oxycodone, Oromorph, to name a few. Fentanyl patches got up to 100 micrograms and I still had breakthrough pain. On patch changeover days, awful cold turkey exacerbated my Raynaud's. Wearing a scarf, gloves, 5 layers of clothing in summer, and I still couldn't get warm. The best thing was being discharged from the pain service because 20% of Lincolnshire patients did not respond to their methods. Next slide, please. I asked for a referral to Nottingham City Hospital, who were using the mindfulness approach to fibro. Although the funding for the 12-week programme had finished by the time my referral came through, luckily the learning lessons remained in place. We experimented with holistic methods that we jointly agreed. More importantly, fibro is easier to manage through self-awareness, actually doing things instead of avoiding them, such as gentle exercising, pacing, engaging things that you enjoy. This slide illustrates some of the things that helped me survive my pain rather than be a victim of it. Next slide, please. In January 2016, I had a cervical discectomy with bone fusion surgery using PEEK inserts. The whole process was very traumatic, from being given wrong medication in recovery, my eyesight being affected and having an allergic reaction to the dressings. I felt so unsafe that I had to discharge myself the next morning, walk to Sheffield train station and get back to Lincoln without any medication. My recovery was slow, despite the surgeon claiming that I would experience at least a 95% improvement in my neck. I felt 1,000 times worse than before I had the surgery. In the 18 months that followed, trying to control the neck pain, pins and needles, heaviness in my arms, the depression and anxiety was overwhelming. Then new symptoms appeared. I thought fibro, fog and fatigue was bad, but this new fatigue and pain was something else. I tried all my usual coping methods, getting out into the fresh air, etc. But I couldn't even get on my push bike. Everything was a struggle. The most I could manage was transferring from the bed to the sofa. I couldn't work or study. I had to give up my consultancy practice. I then noticed swelling in my lower body, particularly my right knee and foot. My fingers became sore and swollen. It was dismissed as fibro. With over 10 years experience of fibro, I knew what fibro was and what it wasn't. Primary care just increased the opioids, but the joint pain and swelling remained. In October 2018, I was so bad that my partner insisted I went to A&E, and again it was dismissed as fibro and implied that I was overreacting. Oh, the joys of gender stereotyping by clinicians who have no understanding of persistent pain. It was a nightmare. I felt lost and helpless. A few days later, I found the NICE guidelines for dealing with suspected rheumatoid arthritis. The clear schematic is pictured on the right of your screen. The primary care team should have followed it. Next slide, please. Now, this is not intended to indicate how bad the potholes are in Lincolnshire. In truth, it illustrates the really hazardous journey of trying to get a proper diagnosis when you have persistent joint pain and swelling. In my experience, if you have comorbidities, you end up slipping through the cracks in a lazy care system, being stuck on the hard shoulder and completely marginalised. Next slide, please. To cut a long story short, it took another 4 years to get a consistent diagnosis of seronegative inflammatory arthritis. Only 3 weeks ago, I was told by a locum GP that my conditions were too complex for him to deal with. I only wanted advice on short-term pain management, particularly at night, because the Depomed injection hadn't worked and there was the inevitable delay in the CCG approving my anti-TNF Benapali injections. Next slide, please. I was only able to cope with the horrendous stresses of a trial and error rheumatology system because of the lovely folks listed here. In my opinion, physio, OT, etc. should not be called secondary care. They were literally the emergency services as far as I was concerned. Helping me deal with the frustrations of daily living was absolutely critical to stop me from giving up. They encouraged me to fight for the right healthcare. Being involved with the flipping pain team helped me to help others understand persistent pain. They all saved my life. Final slide, please. As far as I'm concerned, this slide tells you what local healthcare ought to be doing. I'll just leave that here and drop the mic. Thank you.
Thank you very much, Fan. A question for you. From a patient's perspective, what do you think could improve the overall delivery of rheumatology services?
That's a big question. I have a few points. I think if you're a healthcare professional, keep up to date with guidelines and the latest research, especially relating to pain. Consider incorporating best practice models into your specialism. Listen to patients, and I mean really listen. We do know what we're talking about, honestly. Ask positive questions, such as what do you want to achieve in terms of better well-being? Offer alternatives to medication. Jointly agree a way forward, and most importantly, get OT, physio and the rheumatology nurses out of the hospital and working together in accessible community hubs alongside podiatry, orthotics, mental health and pharmacy provision. This would help deliver holistic healthcare for rheumatological conditions that are life-affirming rather than feeling like a life sentence.
Thank you very much. I think there are very good points in your answer, and it is exactly what the community service should be about, and working together with pain, OT, physiotherapy. It's just impossible not to work together with rheumatologists, for us rheumatologists, I think so. But yes, indeed, it's not working properly everywhere yet. Thank you very much, Van. Let's step forward to our next speaker and presentation. She's Maria Cunningham, and she's a rheumatology clinical nurse specialist in Herts Valley Integrated MSK service, and she will talk about the nurse's viewpoint. It's over to you, Maria.
Thank you, Dr. Christina, and good afternoon to you all. My name is Maria Cunningham, and I'm a rheumatology nurse practitioner based at Herts Valley MSK service. Next slide, please. This is an overview of the topics that I'll be discussing today. Next slide, please. So we believe the pressure from rheumatology secondary care, and this is by providing our patients with common rheumatological conditions, specialist service in the community. This is ongoing care for those with confirmed diagnosis of inflammatory arthritis, our stable reviews patients, which is a cheaper service for the CCG. According to recent data, MSK conditions affect approximately 9.6 million of adults in the UK. The MSK clinical review and triage services reduce the demand on local secondary care, and the potential to reduce referrals by 20 to 30%, equivalent to 2 to 3% of all GP referrals. Next slide, please. We facilitate an easily accessible service by complementing the care provided by GPs and hospital consultants by offering a regular treatment and monitoring closer to home. Patients don't have to worry about organizing transport, parking. They can be seen close to where they live. Evidence also suggests that community-based healthcare, when delivered well, benefits patients. A review from the NHS highlighted that patients with long-term conditions, such as inflammatory arthritis, would actually prefer to receive specialist healthcare closer to where they live. The NHS 5-year forward view encourages efforts to deliver a more healthcare service out of acute hospital and closer to home, and this aims at providing better care for patients. Next slide, please. We offer rapid and flexible access to care by having an effective triage system in place. So rheumatoid arthritis patients are triaged into care to start treatment. This reduces wait for the first appointment, which facilitates early diagnosis. As a patient illustrated before, in our own words, time is joints over time. Early diagnosis and access to care in rheumatic and musculoskeletal diseases, the ideal world and reality. By reducing waiting times, we improve patient experience and we facilitate a two-way communication between both primary and secondary care. Next slide, please. Thank you. We work collaboratively with doctors, allied health professionals, physios, our pain team, as well as other colleagues, in order to manage rheumatological conditions in patients. We deliver a holistic, patient-centered and individualized care approach. People with rheumatic conditions not only face physical symptoms such as pain and fatigue, but they also have to cope with the emotional impact of having debilitating chronic disease. Therefore, paying attention to their emotional mental state is an important aspect of overall well-being, and is an important part of managing rheumatoid arthritis. Next slide, please. We use an electronic system, System 1, which has been accredited by the government's program in modernizing the IT in the NHS. By doing clinics at SWEX, I've been able to access patients' medication as well as results, which facilitates communication and the consultation itself. This is NHS Vision, one patient, one record model of healthcare. The aim is that by 2024, all data will be captured, stored and transmitted electronically. This will be supported by a robust IT infrastructure and cybersecurity, and it will cover the whole country. Next slide, please. We also use the Acrex system, so no need for a face-to-face appointment. Both patient and clinician join a video call. Telephone video appointments can then trigger face-to-face appointments when there is a clinical need. Alternatives to traditional appointments, where appropriate, include digital appointments, which is better for patients. It supports a more productive use of consultant time, and it also enables clinics' capacity to be used more efficiently, providing patients have an Android phone. Next slide, please. We have regular staff meetings, which proves to be an ongoing opportunity for learning and support. A weekly meeting with rheumatologists from Harts Valley and SWEX. We have an opportunity to discuss the service and clinical cases. A weekly meeting with SWEX rheumatology specialist nurses, what we call a downtime, so an opportunity for to support each other as a team. Monthly meeting with SWEX rheumatology nurses to review protocols, and regular clinical supervision is in place, which can be tailored to either group or individual. Next slide, please. We have different training opportunities. I was able to join the academy and have a refresher on both subjective and physical examination of joints. Pharmaceutical teams meetings, an opportunity to keep up to date with new treatments and guidelines. Our RCN webinar, professional development, and an opportunity to discuss the future service. Arena 2020 webinar series, as well as further training opportunities, international and national conferences like PSR and ULR. And I think we'd all agree that we must invest in the education of rheumatology nurse specialists in order to avoid crises in care of patients with lifelong, painful and debilitating conditions. Next slide, please. As we come to an end, by using the resources available, following the guidelines and working with an excellent team, it is possible not only to effectively treat MSK conditions in the community, but to support people in making positive changes to their physical and mental health well-being. Together, we aim at making every contact count. Thank you.
Thank you very much, Maria. Just a quick question for you, if you don't mind. What is the most rewarding part of your work as a specialist nurse in the community service?
I've always been passionate about working in the community, so it's great to bring my skills from the hospital setting into the community. It gives me great job satisfaction, flexible working, and also knowing that patients like to be seen closer to home, and I'm part of that.
Thank you very much.
Thank you.
Thank you so much. Thank you, Maria. Let me just take the option to remind you to pop your questions in the Q&A section, and we will answer them at the end. And I also would like to remind you that if you go to the Connect Health Change webinar webpage, you will find all the previous webinars uploaded there. So please feel free to choose whatever you will wish to listen and watch from the recordings. And also you can find the bios of all the speakers on that website, both today's speakers and the previous webinar speakers. All right, let's continue, and I'm very pleased to introduce you next speaker, Dr. Louise Warburton. She's a GP with special interest in rheumatology. She's also senior lecturer in Keele University, associate medical director, and works in Shropshire Community Health NHS Trust. Her talk will be about a primary and community care perspective, learning from advancements and other sectors. It's over to you, Louise.
Thank you. I hope, yes, you can hear me now. Thanks. Next slide, thank you. So I work in Shropshire, which is a county in the middle of England, next to Wales, and our clinic is in Telford. I've put a map up here because people often have no idea where Shropshire is, but it's a lovely rural county. Next slide, thank you. And there's been a long history of musculoskeletal redesign in Shropshire. I've worked here as a GP for about 30 years now, and I think the first thing that happened after I finished working in the hospital rheumatology clinic was that our very limited rheumatology service in Telford was threatened when our consultant left. So I was really happy that the CCG was supportive and allowed us to move our service out into the community. So we actually developed a community rheumatology service in 2011, which I haven't put on this slide, but is fairly relevant to this talk. So that was a service in the middle of Telford with 2 consultants, a dedicated rheumatology specialist nurse, physios, and myself. So we worked happily there for about 4 years, and then the CCG decided, because of increasing orthopaedic waiting times, that we should develop a fully integrated service. And they wanted a service which encompassed both orthopaedics, rheumatology, pain, physiotherapy and podiatry. And I was very pleased to be on the winning team for the tender. And we were able to establish ourselves as the Telford Musculoskeletal Service in 2015. Next slide, please. And we're a fully integrated service. We're entirely NHS apart from the pain management solutions part of our service and a small physiotherapy clinic called the Maddox. But we work across Shropshire, both with the Acute Hospital Trust, the Shrewsbury and Telford Trust, who provide our orthopaedics, and the Robert Jones and Agnes Hunt Orthopaedic Hospital, who provide us with orthopaedics, and the rheumatologists who work in the community service in Telford. So we incorporated the community rheumatology service into our service at that time. And this was a fully multidisciplinary service with a single point of referral. So this was a new development for Telford. So a GP referral came in electronically through one portal and was triaged and sent to whoever we felt was the best clinician to see the patient. A very important part of our service when we first started was primary care education. So speaking to our local GPs about the new service, about the NICE guidelines that were mentioned earlier, telling people about the early arthritis pathways to try and get everything running smoothly. And we have a clinical hub and spoke model. So the clinical hub is here where I'm sitting at the moment in the middle of Telford, but we have several spoke clinics, including the rheumatology service. Next slide, thanks. And as I said before, the single point of referral was the linchpin really to all this, and involving all our local GPs. So we triage referrals that come in electronically, and we have a whole team of triagers, including Band 7 physiotherapists who read the referral when it comes in at first stage. And then anything complicated or rheumatological comes on to me and a team of extended scope physios and Band 8s who will also triage again and decide the best place. The rheumatologists are working in close cooperation with us, so we have conversations about where the best place for a person to be seen is. We do reject anything acute or 2-week rule referrals, and importantly, we have new pathways for treating osteoarthritis, pain and fibromyalgia. And when the integrated service started in 2015, I was really conscious at that time that there was quite a good service for people with inflammatory arthritis, but anyone with a condition which was slightly harder to define, such as OA or some aspects of fibromyalgia, they were just not getting a very good service at all and were being dismissed without any support or treatment. So that's why we have got our own in-house pain service, and we've also employed, which was Pain Management Solutions, but are now run by Connect actually, pain service to help us with our more complicated patients. Next slide, thanks. So again, this is just a recap of how things work. We get about 200 referrals each week at the moment. Our population in Telford is 160,000. We do have advice and guidance as well, which is used to manage some of the rheumatological conditions particularly. Next slide, thanks. And in 2019 and 20, this is a breakdown of how our referrals were managed internally. So the first bar on the left is the total number of referrals, 12,000 that year. And you can see that moderate number went on to a consultant orthopaedic surgeon. The ESP saw a similar number. gypsies, so that's myself and one other part-time doctor, saw a few. The rheumatologists saw a small number as well. So we were able to hopefully deal effectively with lots and lots of conditions without involving a consultant at all. Next slide, thanks. And this is also a breakdown of the numbers referred to each speciality, which is similar to the previous slide, really, but larger. And again, you can see that gypsies and ESPs are managing quite a lot of patients. Next slide, please. Our currently rheumatology referral rate has obviously been affected by COVID. We had a big spike in March because of the end of lockdown. It's very variable and it's going up all the time, I have to say. So even with our effective internal triage processes, our poor rheumatologists are getting quite overloaded, really. But there's obviously been a big backlog from the past 12 months due to COVID. Next slide, thanks. And we're just undergoing a huge redesign again because the Telford service is teaming up with the Shrewsbury side of the county to make an integrated service across the whole county rather than just in Telford. And this is really just rolling out the principles that we have in Telford across our county. Next slide, thanks. And so in conclusion, I would say that having worked in this service and being the clinical lead for 6 years, really robust clinical triage is important, and you have to adequately resource that time. You can't expect people to be triaging referrals in between seeing face-to-face patients, and we have lots of support and training for our teams around that. And by doing this, we ensure that the right person is seen in the right place at the right time, which adheres to all the GIRF principles. That's getting it right first time. But we've been adhering to those principles now for about 6 years. And I think that's the last slide. Thank you. Yeah.
Thank you very much. Thank you, Louise. Just a quick question for you. What are the advantages for your patients in attending a fully integrated MSK service compared to a simple rheumatology clinic? What do you think?
Well, as I say, when I first was setting up this service with a lot of help, obviously, I was really conscious that patients who were being seen in the acute trust by the rheumatologist were being told that they didn't have inflammatory arthritis, therefore they were discharged without any support or help. And I think because we all work virtually in the same building, there's lots of conversations going on about supporting people and who would be the best person to help this patient, so that it's really benefited our patients.
Thank you very much. It's highlighting again this integrated work together of pain, physio, OT in the community. It's much easier, isn't it? Than in hospital environment. Thank you so much for your talk. And I would like to continue and introduce our next speaker, who will be the last in the row, and then we will go on the Q&A. And I still encourage you to pop your questions in the Q&A section. So our last speaker will be Dr. Benjamin Ellis. He's a consultant rheumatologist. He's head of specialty rheumatology at Imperial College Healthcare NHS Trust. He's also senior clinical policy advisor versus arthritis, and he will talk about the benefits and challenges of primary, community and secondary care provision. Benjamin, this is over to you now.
Thank you so much. Ooh, excuse me. Thank you. So next slide, please. Hopefully we're on slide 39. So yes, I'm going to talk today a little bit about some of the benefits of working more closely between primary care and specialists, and thinking about how relationships and closer working can hopefully really change things for people living with chronic musculoskeletal problems. And one of the things we've heard today from all the speakers, I think, is the importance of all the different people involved in care and the relationships and the connections between, how when that doesn't go well, those relationships and connections aren't there, where the quality of care is so much worse. This slide is the comprehensive personalised care model published by NHS England that all of us are supposed to be working to over the next few years. And actually, it's a very common pyramid that many of us will have seen before, Kaiser Permanente pyramid, with things that the whole population needs, and then the thinking about what people with complex needs need at the pointiest end of that. And the personalised care model really wants us to embed, and I don't know if this might be too small to see on the slide, but practices such as shared decision making, social prescribing, connecting people with services in their communities and other people in their communities. Everybody should be able to access that type of care. And then for people with greater needs, really starting to think about personalised care and support planning. We're going to say a little bit more about what that is today. And then you get right onto people's very specialist needs, what people need. And a lot of the things I'm going to talk about today are the middle section, the people with long-term physical and mental health conditions, which is a big chunk of the population. And what we know is that people with complex chronic pain often fall between two cracks, that they, on the one hand, don't get the specialist care that they might need in a specialist setting, and on the other hand, their conditions are often not particularly well recognised in primary care. We've heard a little bit today about fibromyalgia. We know that high impact chronic pain, that's chronic pain which is very disabling, affects perhaps 1 in 8 people in the UK. But if you were to look at the policies around primary care and the practices and the incentives, you'd think this group more or less didn't exist. Can we move to the next slide, please? So this is the work that we are hoping to start doing in Northwest London, and hopefully we're looking at slide 40 now at the moment. So what do we want to do with personalised care? Well, this is John. John's 59, who used to work, and he now has developed, after developing back pain, he's now got worse problems with exhaustion, brain fog. We've heard a bit about brain fog today, struggling with the stairs, struggling with personal care, starting not to go out, not to see other people, and really not coping well at all. And so if we look at the green boxes at the bottom, and this is what we're trying to do now in Northwest London where I'm working, is we want to define musculoskeletal health as a population health priority for the area. So this is going to involve workforce development, supporting first contact physiotherapists and other practitioners, link workers, social prescribing link workers, practice nurses, as well as GPs. Not quite sure how they fell off the box here. And what we're going to do is we're going to identify people like John and say, we'd like to offer you a personalised care and support planning conversation, not a consultation, something unstructured where you come up and we will mainly be in a listening mode and asking you questions rather than telling you things. Now, we tell him in advance so John has time to prepare, and we give him some information to help him prepare. And what do we hope are the outcomes of a conversation like this? I'll say a little bit more about this. Better understanding that medical therapies are unlikely to remove the pain for somebody like John. And again, we've had mention of NICE guidelines, and we can talk more about the NICE chronic pain guidelines if people want, but they're really emphasising that for people with this sort of complex chronic pain, there's really only a minimum role for medication. But that what we'd like to support John to do is make the changes he'd like to make to achieve the things he wants to achieve for his health. So he sets those goals and we identify the sorts of support he needs: community support, physical support, mental health support, and others. So what are the outcomes we're hoping to see? We want to see better health and well-being. We want to see all their needs met, not just their physical needs, social needs and psychological needs, restoring self-confidence using local services, interdependence with local community. We talk a lot about self-management as if people were islands, but actually none of us is islands. We live and work in communities, and what we want to do is be connected with our communities, and that's what health is about. We can't just train people to manage as individuals. And then we can maybe save some money by reducing inappropriate or unsafe prescribing. reducing low value frequent appointments in primary care and referrals, and try and reduce the pinballing around the system that so many people with these conditions talk about, and reduce the frustration among patients and staff as well, because we know these consultations, when they don't go well, are very uncomfortable for staff and for patients. Next slide, please. So the goals for the service, the goals for what we wanted to do was to improve health and well-being, address health inequalities. Many people on the call on this webinar will know, but there's a huge inequalities around chronic pain, with people who are from more disadvantaged communities in particular having much higher prevalence of chronic pain and much more severe chronic pain. Some ethnic groups are more, or some people from different ethnic backgrounds are more affected by chronic pain, and women tend to be more affected by chronic pain than men. There are other health inequalities as well, and so we need to tackle those. And I won't go into detail comparing the traditional ways of delivering care versus a personalised care approach, but there is a link there to a YouTube video of a group in the Northeast who've done some fantastic work, and this was a presentation they did with Arma talking about personalised care and support planning. If we could move to slide 42, I'm no longer seeing, I think, what you're seeing, but if you're on slide 42, we're in a good place. So this is the pathway that we talked about arranging. And, oh, excuse me, I just need to bring up my prompts now because I can't see the slides. So we need to identify people with a chronic musculoskeletal condition. We invite them for a conversation about their health, resources to plan for their conversation, and then people attending the conversation. And typically we think this is about a 30-40 minute conversation. And then two next elements: health professional is going to work with the person, and that could be a general practitioner, it could be a clinical pharmacist, it could be a first contact physio or other practitioner, and it could perhaps even be a social prescribing link worker. We're testing out different models to see what's needed. There's a lot of assumptions about what's needed. And then for people with more complex needs, the health professional works with the person to identify the MDT team who can support, and I'll say a bit more about that on the next slide. And then there's a review period agreed, and if necessary, others in the MDT can follow up as well. So next slide, please. So this was a bit about understanding, as we started the work locally, what the situation was. We know I've talked about the high impact chronic pain nationally, but it's really difficult to know what's going on in individual primary care networks. And we audited one practice and we found fibromyalgia, which is a lot of the people and conditions we're talking about here, was really undercoded. In a population that size, you would expect maybe 400 or so based on what we know about fibromyalgia prevalence, but only 78 people had that code. So it can be hard to find the people that we most want to support here. But among the group, we found a lot of unemployment. We found high contact rate with GPs, so people attending on average more than once a month, often unplanned, often to see the duty doctor, so not getting good continuity. Seeing a lot of different specialists, sometimes 2 or 3 referrals a year to specialists for many different problems. A high prevalence of poor mental health, many comorbidities, and significant polypharmacy, more than 7 repeat meds on average per person. But within that, also finding a lot of inappropriate, I've said analgesics, but we're talking about medications such as opioids and gabapentin and pregabalin, which have no role in the treatment of fibromyalgia. And so, and we think into the hospital, we're getting up to 40 referrals a month for people with a label as fibromyalgia can we see and support. Next slide, please. So this is the pathway that we developed, and I'll talk through this quickly. But it begins with the GP. The practice working at the moment is doing this with the GP. So the GP will review the notes, inform the person that's coming that they're going to have this sort of conversation, and beforehand we're measuring the musculoskeletal health questionnaire and patient activation measure as well. In the consultation, it's a patient-centered, person-centered conversation, asking people what they want and what people want to achieve. exploring their journey, which is a lot of listening, what has happened to you over your years living with pain, because often people are telling us they don't feel they've ever had their chance to put their story down in front of one person in one go and have somebody help them make sense of it. And then talking about what the diagnoses they have mean, and then goal setting, moving things forward. For people that need it, the GP is then able to have an MDT over using Microsoft Teams, and that's at the moment with me, a health psychologist. I've discovered health psychology as a profession in the last 2 years, and they're an extraordinary, wonderful profession to work with for this work, and a physiotherapist with an interest in chronic pain. And then we've also had social prescribing and clinical pharmacy there. And then finally, the GP will then go back to the person, share the discussion, share the thoughts, put in an action plan for what they want, and then following up with recording it and making a plan for the future. And then there'll be a follow-up measurements as well. So coming to the final slide, so what have we learned so far? Well, what we're hearing from patients or people that are seeing us this, well, people are really valuing the time to talk. People are reporting saying that because of their brain fog, because of their problems with memory, they can't cope with multiple short consultations, and one slower, longer one with time for preparation is very helpful. People are value being able to not just have to bring a single problem, but to bring multiple problems. And people really value feeling listened to, feeling believed, and not judged for the symptoms that they're bringing. One person said it made them feel human again. And you think, what sort of health services do we have that leave people not feeling human? And none of us went to medical school or nursing school or physiotherapy school or any other school to make people feel inhuman. And people did feel increased motivation to try things. The clinicians that have been involved have said they feel increased confidence about making a diagnosis of fibromyalgia or complex chronic pain, and feel they have got much better in their explanations. They have on occasion joined me or a physiotherapist having a consultation over Teams with the patient at home, the GP in the practice, and then us in the hospital, and we've had a three-way consultation. And the GPs have found it incredibly helpful to learn about how people that talk about chronic pain all day are able to talk the language we use and how we help explain chronic pain and how to, and living with chronic pain. And then we've had things at practice level which are interesting as well, that generally other clinicians in the practice who aren't directly involved with the work are starting to feel a culture change, more willingness to make diagnoses of fibromyalgia, more confidence talking about it, more confidence understanding what medication can, or in fact with fibromyalgia mainly cannot do, and anecdotally starting to hear that patients are beginning to consult, that have been through, are starting to consult less frequently and more open to conversations about healthier adjustments in medication. So really that's where we are. We're still at an early date. It's always interesting to present work in progress. This is absolutely work in progress, and we're hoping in the next few months to start to be able to collect some more solid data. But it feels like an interesting way to connect specialist care and primary care, really embedding this work in primary care. So thank you so much for listening, and thanks for inviting me today.
Thank you so much, Benjamin, for this excellent presentation. I think you are doing something extraordinary job there, and I hope it will be really successful. Where do you see the community MSK service in this work?
Yeah, it's a really good question, because this is about supporting people who are remaining in primary care and to remain in primary care. And that's not to say there isn't a role in terms of diagnosis and in terms sometimes pain management programs and other things of people leaving primary care for a period and doing something somewhere else before they come back to primary care. So I think we need to see how the two will integrate together. But there's a huge missing piece at the moment, that people might come into a community MSK service, have some support for a time, but then they come back to their general practice, which isn't equipped for the ongoing support that people need. So actually embedding it in primary care, I think, means we'll be able to get these sorts of services to a far greater group of people, and also the continuity over the course of the many, many, many years people will live with these conditions is something that a community service or a hospital service or a service which is outside of somebody's primary care network would struggle to provide. So I think we need to understand the role that both can play, and I'm sure there is a role for both in this.
Thank you very much. Thank you. So now we have some time left for our Q&A session. So what I will do, I will search for the questions and I will ask our speakers one by one. Let's start with Fan. If you are ready, Fan. So there is a question for you in the chat. So how can we work together? Oh, sorry. I like your idea of asking positive questions. Can you give me an example?
Yeah, so one of the things that most people are ready to do when they go into the doctors is perhaps just list a stream of how awful they're feeling, which of course is what it's for the first initial consultation. But as Benjamin has just said, it's very difficult to get all that down. And sometimes it's actually better for the clinician, the healthcare person, to actually say, you know, how can we work through this together? Where do you want to be in terms of your healthcare? What can we jointly agree with this? And then also as part of that conversation is maybe help them focus on actually what they like doing, because in my experience, what we tend to do when we're living with pain 24/7, we focus on the negative, and it's really hard to remember all those things you used to enjoy, and you usually lose your identity very quickly, particularly if you have to give up work and social occasions. So sort of tipping it round into that positive thing that say, let's do this together. What can we do, you know, while we're helping you to get a referral somewhere? What are the things that you like doing? I mean, and if anybody has the time or the inclination, if they do look up the power of the positive question and appreciative inquiry, it's a really interesting method of tipping negative situations into positive situations, but not ignoring the problem.
Thank you very much. Yeah, listening to your speak, it was clear that, and even from Benjamin's talk, but we know from our experience, everyday work, that listening to the patient is the first very important thing, and unfortunately clinicians many times miss it. But the second one, to give a way out or a perspective or where we go, and giving some positive thoughts and talking about positive aims and targets on this route, that's very important. So yeah, I understand. Thank you very much. Maria, a question for you. What are the pros and cons of community versus acute delivered rheumatology services? What do you think?
I think it's a great opportunity to work with a team, collaboratively with a team of physios and specialists in pain. Patients do value the service, and I think in secondary care it's different. But I found that from what patients say, they want to be listened to, and that goes back to what Fen was saying. You know, they do want to be listened, and pain is a big part. So I found having this relationship with colleagues benefits patients.
Thank you very much. And as a nurse, do you feel any advantages working in community compared to when you worked in secondary care? Is there any differences?
Perhaps it's my perception, but I find a more relaxing environment. It doesn't feel as stressful. So perhaps it's just my own view. I've always I've always preferred the community, but I couldn't do rheumatology in community until I joined the service. So it's great that I'm able to use the skills that I've acquired in secondary care.
Thank you. Do you think, is there anything the student nurses could be attracted by to choose this path to become a specialist nurse in rheumatology?
From my experience in the past, student nurses, their first perception when they used to come into clinic was that they wouldn't enjoy the experience, that the rheumatology was a rather dull field. But actually, the nice thing was that by the time they finished their training or spending time with me, their view was completely different. They really enjoyed, and they learned a lot about the chronic conditions, and they found it as rewarding as me, which was an achievement. So I think we just need to talk to the student nurses about the specialty, and I think once they get the opportunity to shadow one of us, then I think if they have a misconception, I think it will change for into a better opportunity and specialty.
Thank you very much. Thank you for your answers. The next question is to you, Louise. The question is, do you manage inflammatory patients in your service? And if yes, in what form, what type of patients?
No, I don't personally, because we're working with 2 consultant rheumatologists. So I might detect that someone has inflammatory arthritis, but the triage process would aim to get those people in front of a rheumatologist first. But as I do diagnostic ultrasound for synovitis, I do scan some people who, when they were referred in, appeared to have an OA perhaps. I might find that they've got rheumatoid, but I wouldn't start them on a disease-modifying drug. I used to do that in the hospital clinic, but I don't anymore. I tend to manage the patients who've got non-inflammatory disease.
Thank you. And your rheumatologist colleagues, those colleagues who work in the community, they are seeing these patients and they are initiating the DMARD therapy?
Yes, that's correct. Yes.
Okay. And do you keep these patients long-term in your service? So do they stay with you as stable patients? Do you look after them?
Yes,
so
we do.
You don't have to send them to secondary care at all?
No, because the consultants who work here also work in the, it's not the acute trust, but it's a specialist orthopaedic hospital in Oswestry. So if anyone was so ill that they needed admitting to hospital, they would either go to Oswestry or to the acute trust. So no, we're all part of the same health economy really, and with the integrated care, care services, we're even more integrated now. Yes.
Yeah, that sounds like that. It's a very advanced service, I believe. So it's quite a unique structure, but really good. Thank you very much. Thanks. Thank you. So Benjamin, and a question to you: where should pain management programs sit? What do you think?
Well, pain management programs definitely have some role. I think at the moment, I want to say 2 things. So first of all, I think there is some uncertainty about pain management programs being raised by the NICE guideline for chronic primary pain, which wasn't able to recommend pain management programs. So it made other recommendations, but it wasn't able to recommend pain management programs as such. And I think that creates a question about exactly what should be available. And I think at the moment, in the absence of clear guidelines, every area is having to work that out for itself. I think that clearly some people benefit from pain management programs, but given the sheer number of people with chronic pain who are struggling, and we know there are many millions in the country, if it's 1 in 8, pain management programs are only likely to be a small piece of the answer. So I think we need to rather than saying there are a huge number of people with chronic pain, what we need to do is massive increase in the number of pain management programs. I think we need to focus on enhancing and supporting the other parts of the system and other areas of support, and then understanding more where pain management programs fit in. And I suspect what it will be is the providing really high quality primary care and supporting our primary care colleagues to do that, and we provide so people are able to get that. Then there'll be a smaller number of people who are struggling in spite of that, and they might be appropriate for being referred to pain management programs and or to other services. So again, nice recommendation in chronic primary pain was thinking if people have mental health needs or want to explore the mental health side of chronic pain, referring people for that, and if people want to explore the physical activity part, referring people for that, but again didn't find the evidence that combining them was any better than doing them separately. So we need those services available for supported physical activity, to support people's mental health, to support people to use mindfulness and other techniques to manage their pain. That's very important. But how many people exactly will need those in a world where we had really high quality primary care, I think we need to see. But it's not to denigrate the other services, not saying everything can be done in primary care, but we need to make sure the primary care is there to support the vast numbers of people who, some of whom perhaps will still need more intensive input.
Thank you very much. Yes, I think the impact of pain is more and more significant in all services, and obviously widening those who can manage it would help definitely with the problem. I'm just wondering if the primary care colleagues after the COVID, how much they can deal with it, but hopefully in long term, they will be able to develop their skills and their knowledge and change approach and help more with patients for patients with pain. Thank you very much, Benjamin. The questions are coming in, so I go back again to Fan. Fan, there is a physio question for you. Was there any specific treatment that you found helpful from a physio perspective? Did you go group work or aquatic therapy at all?
No, I didn't do group work because, I was so embarrassed about the way I was, and I do find personally group work a bit difficult, but I was really fortunate that the physio I saw, she really did know her stuff. She sat me down and she just looked at me, and she just looked me up and down, and she said, "Why are you holding your head that way?" And I'm like, "What do you mean?" And apparently I've been holding my head to the left for a very long time, and it completely affected my whole posture, even to how I walked. She put me in the gym between the two bars. I'm not sure, they look like ballet bars. I'm not really sure what they're called. She put me on a wobble board. She was so mean to me. She made me walk upstairs. But actually what she really did for me was teach me how to walk properly, how to keep all my limbs loose. I don't know if you've ever seen the video or the advert for a thing called Mr. Soft. It was about sort of soft sweets, and all the things in the sort of street, and including the person, was sort of just really sort of being loose with their limbs and just taking it steady and sort of bouncing along in a buoyant way. And that gave my confidence back. And one of the important things is when you're in a lot of pain, you don't make eye contact with people and you put your head down, usually to make sure you don't trip over anything because you're so worried about damaging yourself, but you just protect yourself too much, and holding yourself tense, as all the physios will know, is the worst thing to do. And I learned to put my head up and look forward, and I can't thank Carol Thacker enough. She was brilliant.
Thank you very much. Really appreciate your honesty here, and I think it reflects very much what Benjamin talked about, the personalized care. So especially for patients with mental health issues, chronic pain, I think it's really, really important that we don't force them to fit into groups if it's not the right thing to do for them. Thank you, Fan. Louise, a question for you. Triaging seems to be a key factor in the service. Would you share your services triage criteria?
Probably not, no, because that is intellectual property, isn't it? But we use all the NICE guidelines. So, for example, the early arthritis pathways entirely based on the NICE quality standards for getting people in front of a rheumatologist within 2 weeks. So we've just built them up around the evidence that's out there, and obviously you have to take into account your own local health economy. If we don't have a spinal surgeon on this side of the county, so that means we have to be very sure that patients who are triaging to see a spinal surgeon really need to see a spinal surgeon. So that's what I would say. And perhaps if someone wants to contact me personally via email, I could elaborate on that more.
Thank you, Louise. And you mentioned that even the triaging is leveled, so there are different people with different knowledge and background triaging different referrals. So I think that's a key factor, isn't it? That it's the point of success triage, but there's a team behind it, and you
definitely. And then there's always a communication pathway so that people receiving the referrals at the first stage can ask people who are more experienced or know more about rheumatology what to do with this particular patient.
Yes, thank you very much. Do you have any training for your colleagues for triaging?
Yes. So I probably do most of that, but obviously we have team meetings and we all learn from each other and discuss particular problematic referrals. Or the main problem we're having at the moment is due to COVID. People are not being seen face to face, so we might be getting referrals from first contact physios or physios saying this patient's got neck pain, can you see them, without there being an assessment performed in primary care. So we're having to push back a bit on that, because now the restrictions are somewhat eased, aren't they? We would like patients to be examined, please, before they're referred in.
Yes, definitely. Yeah, this is a problem now. And also I think the quality of the referral letters also something. And you mentioned you are educating the GP colleagues about, and you see both sides. You are a GP yourself.
Yes.
So exactly when you refer patients. Thank you very much. Thank you, Louise. For Benjamin, another one. How do you address the patient's feeling that they need more investigations and that something has been missed, especially in the case of some patients with fibromyalgia who are struggling to accept they have the condition? I find this can be a big cause of the pinballing among different health services. I really like the sound of the personalized care approach though, and I think this would be very valuable in our area.
Yeah, it's a really good question, and of course, and again, thinking about Fen's presentation earlier, her story that she shared with us, that of course people with fibromyalgia do also develop other problems. And again, I'll point people, if people haven't had a chance to read the NICE guideline, the emphasizing, if somebody has a flare, remembering to go back and take another history of the flare and examine again and reconsider whether somebody might have developed something else, or something that looked like fibromyalgia before might now have become something else, because people with fibromyalgia get Cauda-Equina syndrome and they get everything else that everybody else gets. So I think that's a really important point to emphasize. I think giving people more time, really hearing people's stories and listening carefully and doing a careful clinical examination is key. It's how we were trained to work, and I think it's absolutely critical to making a diagnosis early on and saying to people, often in one of the first consultations about their chronic pain, is saying, I think you might have fibromyalgia, and explaining a bit about what it is, and then saying what tests you think are necessary to exclude things that aren't fibromyalgia as well. So sometimes, you might be saying, well, I think we ought to check your inflammation markers. I think we ought to do whatever else you're going to do. We ought to check your thyroid function and your HbA1c. So there's a small number of tests that you might do. I think a lot of the pressure for tests comes from people feeling they haven't been taken seriously. And so if we take people seriously and we give them the time, and it does take time, I think that happens less, but we have to have these conversations with people, and when people are worried, think about, well, what will help? Now, we know very often that more tests can just increase the level of anxiety. So we know there is always a balance. We've always got to use our clinical experience and make shared decisions and say, this is why I think you shouldn't have it if we think somebody shouldn't have it. But if someone's saying, look, I'm really worried I might have cancer because my mother had bone cancer and this is why I'm really worried, well, having a conversation about why you don't think it is and what investigations you do or don't think are appropriate. I think it does have to be a conversation and negotiation, and sometimes that's agreeing to a review. I think what's the pinballing, I think, happens when nobody early on says, for example, with fibromyalgia, that I think this could be fibromyalgia, but we need to do some tests, or I think this could be fibromyalgia, you're getting palpitations. Actually, a huge number of people with fibromyalgia do. I think it's reasonable, we'll get an ECG, but more than that, I don't think we need. But maybe somebody you do think they need more, and you have to agree it at that point. But if people have got that anchoring diagnosis of fibromyalgia at the beginning, it's not, there is, I think, almost always less of the pinballing and less of the repeated consultations in primary care because the anxiety level is so high. And there have been 2 or 3 studies showing that if people have a clear diagnosis of fibromyalgia, they start to use less health services because they feel listened to, they've got a clear, coherent explanation of their symptoms, and then they can start to think about how they manage their care from then on. So I think it's an art, as is much of healthcare. I couldn't give a definite science, but I do think it works when we do it well.
Thank you very much, Benjamin. And there's another question which connects here very well, and Fen, I would like to ask your aspect on this topic. It's the question is that what is your expectation as a patient with a long history of chronic pain when you attend an appointment at the GP practice? I am a new first contact practitioner in GP practice and finding the consultations with patients with chronic pain challenging. What do you think, Fan?
Hi, thank you. Yeah, I've sort of answered it in the Q&A thing as well, but I was lucky that my GP has actually known me since I was 18, so that's great. But for others, I realise it's a challenging situation, and obviously many times people have plucked up courage to come with the issue because it can't be seen. They've probably got family issues at home where they can't, you know, talk to people about it because people misunderstand, you know, when you're tired and you've got fatigue and you look fine, so why is there a problem? And I think the expectations on both sides, I've sort of said that sometimes you need to acknowledge what the patient is saying. You really don't have enough time in 10 minutes to get to the bottom of it, you know, as Benjamin has said, you know, it's just not possible. So hear what the patient's saying, perhaps ask them to keep a pain diary for a month, and that includes their exercise plan, what they like doing, what they like to eat, how much rest they get, and then invite them back in a month and say, okay, let's work through this together. Well, we can see the peaks and troughs or whatever, and clearly you're doing this, and it gives you both an idea of something to work on, to build a working relationship, a partnership, which is what you want, and then together decide the way forward, whether that's in secondary care or through some other means or social prescribing or whatever.
Thank you very much. Thank you. Very appreciate your view on this. And we are running out of time, so I would like to thank everybody's contributions so far. And I have one final question to each of you. If there is one thing, what would you change in the rheumatology services? And let's go in order as you spoke today. So if you could come on unmute first, you, Fan, what is that one thing you would change in rheumatology?
As I said in my sort of the first question that I answered, get the people out of the hospital and into a community hub where there is an integrated service, where people can be quickly involved with situation where they're not waiting for months and months and months to see somebody, where somebody can do a triage situation, as we've said, and pass them over. In a hospital setting, it makes people nervous, and it's not appropriate for a hospital in some cases. Don't medicalise it. I mean, I know it's a medical condition, but don't medicalise it. It's a lifestyle, it's a life problem, and it needs dealing with holistically.
Thank you very much. Thank you, Fan. Next to you, Maria.
Well, Fan, I wish I answered the question first, because that would be the same answer. Patients, stable patients, they don't need to be seen in secondary care. They can be reviewed in the community, and again, a good triage system in place will benefit patients in an immense way. So yes, I think I've just repeated what you said, then.
Thank you, Maria. And to you, Louis.
I agree as well, really. We're trying hard to just keep the rheumatologists seeing patients who they really need to see, but they are still following up all their patients on DMARDs with a nursing team. But we have recruitment problems, and I think we're 2 or 3 consultants down and 1 or 2 nurses. So that's our main problem across the county. The waiting list, and it's now worse following COVID. So more staff and moving some of those follow-up patients out into the community so that people like me could see them.
Thank you very much. And Ben, your thought.
Yeah, if we want to improve the musculoskeletal health of the population, we have to go where the population is, which is around primary care. And if those of us who are specialists in community or hospital services, if we think we haven't got time to support primary care, to support people with chronic pain, I would say we haven't got time not to, because the only way we will help people remain in the community looked after by primary care is to support primary care. And then, yes, then the right people will make it to us at the right time, but we have to put the time in to support primary care, doing a heroic and fantastic job to support people with chronic pain living in the community.
Thank you so much, and really appreciate all your energy and effort you put in this webinar today. Thank you for all our speakers, their contribution. And I would like to remind our audience that there is a feedback survey. It's put in the Q&A section. Please don't forget to fill this up. This is a feedback survey for us. And also please check the Connect Change website, where you can see the previous webinars recordings, and you can see the program for the next upcoming webinars. Thank you for joining us today. Have a nice afternoon. Bye.